So we are really, really excited to introduce Lucy Berliner.
Very exciting.
She's
EVP.
one of our regulars,
really
and we appreciate her bringing her knowledge and expertise to this subject. She's been working a long time in the dissemination and sustainment of EBPs, so we're very excited to have her. So a little bit about Lucy. She is the director for the Harborview Center for Sexual Assault and Traumatic Stress, and she is clinical associate professor at the University of Washington School of Social Work and Department of Psychiatry and Behavioral Sciences. So her lecture today is on the dissemination and sustainment of EVPs and community mental health in Washington. So I'm going to go ahead and let you get started. All right? And
thanks.
A couple of, reminders. If you do have a question, we're going to send around the mic, so if you could wait for that. We are recording the lecture and want to make sure it gets on the videotape. So that would be really appreciated. Thank you.
Okay, so I'm going to tell you what I know, what is possible to find out about some EVPs that are being done in Washington. And then I've got the idea. I think we are essentially at a crossroads for the whole evidence-based enterprise, and I want to put out some ideas and some data from other sources to show the challenges we've ended up finding ourselves in. Now, everybody knows that it's the law in Washington State to prefer evidence-based practices in juvenile justice, mental health, and child welfare. And in juvenile justice, they do a pretty good job on that for higher risk offenders because the state basically pays for it. In child welfare, they have a menu of some EVPs, some sort of EVPs that they purchase as well. But I'm going to talk mostly about public mental health because the numbers are the biggest there by far. You have several hundred kids getting EVPs in juvenile justice because juvenile delinquency has been solved practically in the last 10 years, right there. It's declined dramatically, and there are not as many kids in that system. And in terms of kids in child welfare, for whom services are purchased, most of the kids in child welfare and foster care, they're getting their services through the public mental health system. And that's over 30,000 kids a year. So that's what I'm going to concentrate on. Kids whose insurance is Medicaid, and they go to the local mental health center to get their care. Because that's, the state doesn't really have the authority to tell other insurance providers what kind of services they have to provide. So it is policy in our state. We prefer this. Here's how you can tell what counts. This is the Washington State Institute for Public Policy. The legislature directs them to do meta-analyses of interventions and come up with lists. And they're pretty strict, and there are a few things that I think are a little bit surprising to people at first glance because interventions that we have two categories. We have evidence-based and we have research-based. And just to explain that distinction, because if you leave Washington State, that's a unique distinction used in Washington, and things that are considered evidence-based other places might not be in Washington. But it's actually for a good reason. So in addition to studies having to meet certain criteria like randomized trials and this and that, and you can see up there, if you have your eyes work, heterogeneity. Well, what they did, and I think this is a pretty good thing, and we all should probably be very supportive of it, is that they looked at the subjects in the study. So the kids who are in these various studies of different interventions, and if the diversity representation in the populations in the studies was off from Washington, meaning if there were not as many ethnic and racial minority kids in the studies as there are in the state of Washington, they go down. So that's the basis for why they go from evidence-based to research-based in Washington. So, because I had a whole big argument with them about anxiety treatment. CBT for anxiety is considered by everybody to be evidence-based. In Washington, it's really considered to be research-based, but that's because most kids in most of the studies are white. So it's a distinction without meaning in some ways, because mental health centers can get credit for equivalent credit for delivering in research-based or in evidence-based. So this is just a list for mental health interventions. There's a list for juvenile justice interventions, and what that means is interventions shown to affect a juvenile justice outcome, mainly recidivism. And then there's a list for child welfare, and that's interventions shown to affect child welfare outcomes, like preventing placement or reducing referral. Here's the utilization in Washington. So you could leave now because here it is. This is what we actually know. So the way that the state decided to see if they could track use of EBPs was to put a requirement on provider organizations that when they document their visits with kids for therapy, they would have to, they could add a code that was tied to the WISIP interventions. So most of these interventions have a code, and if you're a provider in a public mental health center, you're supposed to document if you did one of these EBPs. Now, it's never been clear to me, and I haven't been able to get the answer right, is it by visit or is it by client? So you very well could have a situation, in fact, I can guarantee you that it is like this, where some sessions might be EBP and they're following the program, and others might be a crisis response because the kid is suicidal or something. And you're not going to just say, well, never mind, I'm on the plan here. So it's not entirely clear what it means. But this, the legislature required a report to document the percentage of visits, whatever it is, visits or kids, in each RSN. And an RSN is an administrative entity. The state's divided up into them, and they get the Medicaid money from the state, and they issue contracts, monitor them at the local levels. And they are going to magically become something else. They have a new name called BHOs, Behavioral Health Organizations. I have not been able to figure out exactly how they will be different, but we have another law in the state mandating integration of substance abuse and behavioral health, and that's supposed to start in March. And then another integration is supposed to happen in 2020, and that is integration with primary care. So these data are by RSN, which I'm pretty sure, my understanding is the BHOs will be the same entity. They'll just be changing their name in a way and absorbing substance abuse. So you can see that's not exactly an overwhelming high level. And what you can see there, just by the way, half the regions reported zero use, including King County. And that's not really true. I know that for a fact because, number one, we do almost all evidence-based for people in therapy at our shop, and we train lots of people. We have lots of colleagues. What stalled them out on it was because originally the mandate said, you only can report things you've done with high fidelity. And no one knew what that meant, but it didn't sound good. Because I think provider organizations and RSNs legitimately had a concern that what if they were audited? How would they prove, demonstrate, document that people were really doing the EBP? Now, this last year, the contracts now contain a requirement that people will report it, and so we'll eventually see a more, I think the rates will go up. Here's the legislative requirement, is benchmarks. Josh, just go.
Okay, I'll talk really loud. Do they identify what EBPs they're using and tracking? I'd be curious for some of, we're getting to that?
There you go. That's what there is, period.
But it doesn't say exactly what the service is.
This is it.
Okay.
And so you can see the flaw in this because that doesn't help me one little bit because I don't know what the rate is for my clinic, and we are a licensed mental health center, and we're just a little tiny one, but still. And I don't know, what are the interventions? And this is something that I think we need to know more about because there are more data in there. It just isn't come back and out to us. And if we want data to help people in organizations know, here's what we're doing, and here are the EBPs we're using most, or here's the percentage, people have to get the data back. And so that's right there, challenging, because that doesn't help organizations at all. It is responsive to the legislative mandate. So, is that from a report? Yeah, that's from this report.
And that's the Lucy, that's the 2014 report, because I know they have one that's going out that's not yet public. I'm curious to see the...
I'm not in on that.
No, I haven't seen it yet either.
Well, their benchmarks have been set. But even if people do meet them, it's not going to be very useful at the provider organization level unless we get feedback that says, here's how you did in your clinic. That would be extremely interesting and useful to me. And I think, but it's very challenging. Data can go in, doesn't always come back. Now, Sarah Walker from the EBP did what's known as a gaps analysis. It was a creative way of trying to figure out, well, what's the capacity in public mental health in Washington to provide EBP to kids with certain kinds of problems and disorders. So they identified the top diagnoses, and this is what they are. And it's interesting to me that depression is the highest, and that relative to anxiety or behavior problems. And, who knows how accurate the diagnostic thing is, but it's a good little snapshot. And then they figured out a calculation to ask organizations, how many people do you have trained in EVPs for these problems? And they calculated based on the average caseload, how many kids would have each of the diagnoses, and they were able to come up with an analysis. And the unmet need varies quite significantly across RSNs. I think it's RSN-based. And in and there are, as you won't be surprised, there is a gap. In plenty of places, there are not enough providers to do them, because if you're not trained, you can't really do them. Then there are in other places, they have no gap, but that's the intervention that people are most interested in. Okay, trauma. Just for you, Eric, to mention trauma. People like to learn and do trauma-focused treatments more than anything else. So what we've been doing in the last 8-9 years is we found exactly from our informal contact with the mental health centers, because we started off, we were only doing a trauma treatment. And our colleagues in public mental health said, well, that's all very well and good, but as you saw right here, that's actually 9% of kids. And if you're an administrator in a public mental health center, you need to figure out how are you going to serve all your kids. You can't just say, well, these kids get an evidence base and the rest of them, who knows or who cares. So we came up with sort of a novel training approach where we would train people in all four of those top ones, and we chose evidence-based interventions that are all based on the same theory, so that it wouldn't be like people would have to be learning completely different things across the different EVPs. And we also, for 3 out of 4, we chose generic versions, which are on the inventory, so we didn't have to get tied into somebody's company and all of that. Because in anxiety, for example, there are brand name CBTs, but everyone on the planet agrees that CBT for anxiety that contains sort of the standard components is evidence-based. So that was kind of neat, because then we could be very flexible about it. And we use a modified learning collaborative idea, because that's what the research says. You don't want to train and hope. So we have a training in person, and then we have 6 months of consultation applying the interventions to real cases. And we allow flexibility, but of course our message is don't go mixing and matching without thinking about it. Have a good reason if you need to add in something. So the team, it's me, Shannon Dorsey at Psychology, Laura Merchant at our shop, Georgiana from EBPI, and Nat Youngbluth. And this is supported by the DBHR with federal block grant dollars. So we've trained over 900 people. Most mental health centers that serve kids in the state have sent people. We figured out a way to see the difference between sending 3 people in 2009 and never again. That's not investing. That's sending people, and you're not really embracing the whole idea. So about 30%, we'd say, of the 94 have really invested. They send people to every learning collaborative they can. They participate in the other things like the supervisor training. And then we have an advanced talk for the people who've been in it. It's kind of a treat to reward them for doing EBP, so we bring in a named person from out of state. And then we have a lot of resources that anybody can get. Last year, because of this new law about integration, they asked us to create an SBI, a screening and brief intervention, that could be put on top of the CBT interventions, which we have done. Now, that's Washington. That's all I know about Washington. And so I'm not even trying to talk about JJ or child welfare per se. I'm focusing on public mental health, where the largest number of kids are served. Now, if you step back from Washington, the good doctors here, Eric and Sue, along with Mike Pullman, did what I think is a very interesting and it's important to know, but it's not exactly optimistic picture across, and feel free to correct me if I've got your thing wrong. I've read it a couple times, but that looking at all states and administrative data that was available to look at the commitment investment in EBPs over time, and as well to track the use of interventions, the ones they did track. So you can see the ones they tracked tend to be the high-end ones, and some of them were for adults and some of them were for kids. But this is a quote taken out of the paper. That's not exactly what we're hoping for, a penetration rate of 1% to 3% and a flat or declining investment by states in supporting EBP. That's what I meant by the crossroads. And as soon as I read it, I immediately emailed Eric and I said, what's up with that? So we do have one piece of good news, of course, and that is that the attitude towards EBPs has really shifted, in my opinion. We rarely run into people saying, well, EBPs are stupid, or why should we do that? And what I do works anyway. Although I will say we did have an email from somebody who went to one of our learning collaboratives yesterday saying, I'm not going to continue to participate because it's against my personal philosophy to do that kind of therapy. But I think that's rare. I don't see that much, and nor do my colleagues around the country. Our challenge right now is that the organizations and the providers say, okay, we bought into it, we see your point. If it was your kid and you were informed, well, there's a 50% of kids get better with non-specific supportive therapy, and 85% get better. What are you going to choose? Everyone's choosing the 85. No one's going into their doctor's office and saying, give me the placebo. Placebo actually works. I could look at Terry over there and he could tell me how much of the improvement you see with antidepressants is accounted for by placebo. Quite a bit. So I'm all for placebo. I consider it the C in CBT. But we don't run into that. Here's where the problems are. Everybody's just found out. Well, the training doesn't end once you've trained a few people. The rates of turnover in public mental health, they're 20, 30%. So you have new people coming in. So they all have to be trained too. To support and keep it going in your organization, well, that has costs, because that means you've got to be giving people supervision in that model. Everybody knows, the research is absolutely clear. People won't keep doing it if they're not being supervised on how to do it, because real cases are a lot messier than the ones the trainers tell you about at the training. How do you get coverage for every kid who comes in who has a disorder? I've counted it up. I think minimum it's got to be 12 to 14 different EBPs that you would have to have in order to cover kids coming in with all their diagnoses and problems. So we're doing pretty good with our 4. That's going to get you about 75 to 80. But you do have kids with eating disorders. You do have kids with extremely high conflict, dysregulation, infant mental health, ADHD. There's lots of different problems. And, that's a dilemma for these administrators. How are you going to pull that off? How are you going to... We all already know that if people don't do it the way it was tested, you probably won't get as good results. How are you going to make sure that happens? There's no example anywhere that I know of where anyone's doing that in real life without external funding. And the fact is, it's harder to do EVP than traditional therapy, not just for the providers, because you have to have a model you're following, you have to be prepared, you have to have your handouts, you have to follow up on the homework, you've got to be teaching skills. It's a much more focused, structured, and hard work to do it. It's very misleading to imply to people that it isn't harder work than responding to what people bring in the door. And that's pretty much traditional therapy. Treatment as usual is supportive, responding, and random acts of intervention. Little of this, little of that. And clients prefer that other one, too, by and large, because they have a warm, supportive person they can vent to, they can talk about how tough their life is. There's no expectation that they're supposed to be working on something and changing, doing homework in between. And who cares what they do in our office? It all is in the world. Do they think in a more helpful way? Are they doing behaviors that are more effective? So it's a lot more work. You have to not only do all the work yourself, but then you've got to engage clients in doing something that's hard for them. And we're in an environment where there's no sticks, no carrots. There's no reward for it, and there's no consequence for not doing it. So I think that's a crossroad. And we either just keep going down the same pathway, or we start thinking about how do we address the reality of the situation we're in, which is not going to ever be what we'd like it to be. And I might point out, I don't see in Washington any possible way that public mental health is going to increase expenditure on your everyday regular kids. They can't. They've got 3 lawsuits, 2 on adults, and I know for a fact, because I went to a grand round this week, that on the adult side, there's a lawsuit about boarders. You know about boarders? Psychiatrically ill people, that there's nowhere for them to go. There's no hospital beds. Western state shut down and accepting new people. They don't have staff. As you might have heard in the paper, that people are being assaulted left and right. So we have at Harborview stacked up in the hallways, people on gurneys. And the federal court has ruled you can't do that. So they've changed the name of it. So they call it something else, individually approved beds or something. But when a gurney becomes a psychiatric unit, you know what the world we're in. So they have to deal with that. Then there's the forensic side. But then on the kids side, some of you may be familiar with the lawsuit on the kids side. It's called TR. And Terry and I were just chatting about it. And it's for the 5 to 7% highest level kids with the most problems in our state. And there's a lawsuit. The state has agreed to do things in a different way for those kids. So and they would be the first to tell you, the government people, these are our drivers. We have to respond to these legal cases, and we have to invest in those. So what that really means is if 5 to 7% of kids who have high levels of problems are where all the dough is going, that leaves 90+% of kids, your regular kids with mental health problems, at status quo. So that's a public policy challenge, because you can't really hold that against the state. And right now with education and other things, there's not like piles of money going around. So that's a challenge. So these are the things we know from research, that if you have these in real world settings, you can get results that are about as good as in a academic controlled trial. So, and so the question becomes, how do you get that without external funding? How do you do those things in 94 public mental health agencies in Washington state? I don't really know. And that's kind of why I was looking forward to this talk, because I went and did a lot of reading to try to figure out, well, what are our possible strategies on this? Well, to boil things down, I'm a boiling down person. I thought about, well, there are sort of 3 main areas we have to figure out how we're going to address. Workforce capacity, so we got to get people trained so they can do these interventions. The organizational, keeping it going part. And how do we keep it going in the right way? So That's the framework I was thinking. Now, I've been in a lot of task forces, and I'm guessing a lot of other people here have as well. And people in the field, in the government, in the public, in the provider organizations, it always comes up, unless maybe I'm in a different meeting than you. What we need is the training programs, the graduate training programs to train people in EVPs. I would say little or no headway has been made on that, and I'm out in that real world. I talk to people, and the people who, the master's training programs really don't promote a preference for EVPs. Some of them actually say they're stupid, or you don't need to do them, or why should you? And then there's rarely any sort of setup where people can actually do them in real life. So I'm not putting a lot of energy into the pre-service. I think that may be a mismatch between what we think and what academic institutions or other, educational environments. And, where do people go? I mean, they go to Antioch, they go to Leos, they go to Seattle U, they go to the UW School of Social Work. And, so you get a kind of a very mixed bag about what the training is and whether or not the institution even really believes in EBP. So turning to, okay, that's us then. Provider organizations are going to have to figure out how to do it. And so there's the paper out here, and I thought this was great. All these interviews with people, stakeholders, and they all agreed this was important, we need funding, we need it to happen, and they did this. And this was done in Philadelphia, which has done a lot of work in this area. But it's like, well, we think the government should pay for this EVP training. And the government says, no, we think you should pay for it, provider organizations. And there's no real consensus yet about where's the money supposed to come from to train all these people so the workforce is actually prepared to do EVP. Now, I would say we've come up with a pretty good system here in WA through our CBT Plus, because for a while it was all subsidized, so it was free to people. And then we thought, that might not be sustainable. So can we come up with cost sharing? So a couple of years ago, we said, well, we're going to subsidize from the state because we're unbelievably fortunate with DBHR. I cannot tell you how much we appreciate this, because federal block grant dollars are normally scattered around for one-off projects that people are interested, the shiny new objects or the new thing we're interested to try out. And they've sustained their support for us over the long haul, and it's been a fantastic investment from our perspective. Although there's a paper out showing we have the cheapest by far approach per participant getting trained of any program in the whole country. So we're doing a lot on the cheap, but we feel like we got a fabulous partnership with DBHR. So we just started saying we're going to charge providers a very modest fee. So underlying funding, provider organization have to pay by the person a very modest fee, and we have had no problem with that at all, which is really neat. That provider organizations, they were not, because it was so reasonable. So we've had no decline in interest or anything. This past year, the state said they didn't want to continue this one training a year, all the UW people. They wanted it to be a more regional, more access, and they want us to develop a cadre of state trainers, which we have done. And we're right in the middle of implementing it. We've really worked hard on this. So we have regional trainings. This afternoon, I'm going to leave here and I'm going to go to Centralia. And so we have a partner organization, one of the Investeds, who are hosting it. And the reason why Georgiana isn't here, I assume, because she's there now. And Laura Merchant was there yesterday, because our model is one of us and one of our state trainers to do these trainings. So that's been really exciting to see that we can do that. So we have Centralia, Pierce County, King County. We have another one coming up in King County. We've already done one. Yakima and Spokane. So I really think it's going to be a neat, a neat framework for doing it. And then in this past year, we had a new partner, because we thought this would always be very helpful, was the RSNs pitching in. Because we figured you have the state, the RSNs, and the providers. Those are the people who should care. And North Sound has purchased some CBT Plus trainings from us, as well as an adult intervention that we're doing. And then Thurston Mason has indicated they would like to purchase. So I think we're on a good track for the training. But keeping in mind, the training is 3 days and then consultation. That's not keeping it going. That's getting it going. So here's our problem, ultimately. I think you can solve the get training thing with creativity the way we have, but people can get grants for the training and stuff. It's the keeping it going is where we're really going to have to work on it. So I've already told you, it's harder for people. And we're asking people to make a change to do things that are harder and more expensive without any incentives. So if we're going to be doing, it's not, in my opinion, because I'm very EVP, people don't do things without a reward or a consequence. They don't just do them because I want to be a better person. You have to have some reason and incentive for it. And if we don't have that, then every solution we have has to be something that can be incorporated into everyday existing practice. Because I don't believe people are going to do a lot of extra work and invest a lot of dollars without external support. But so we have oriented ourselves, since we aren't waiting for the money to be floating down from the sky, we've oriented ourselves toward solutions that can be done within the existing structure. That you're doing this now, could you do that this little different way? And there are some exceptions, and they're mostly in JJ, which I totally support, where the government will pay for all of it in an ongoing way. Not just the training, not just the learning to apply it with clients, but in an ongoing way. And there are good reasons for it, because, these kids are committing crimes. The citizens don't really like that, because these interventions are primarily for higher risk offenders. If a kid recidivates, they do it quite right away. It's very expensive because they end up going to an institution. And as well, I think it's a very good strategy to slow down mass incarceration pipeline. Because if kids get good services that are effective, Josh, do you agree they're effective? Josh is an MST person. Then they're not going to penetrate farther into the juvenile justice system and then into the adult system. There's nothing more important than reducing recidivism for kids in JJ, because otherwise, nobody should be caring about their PTSD. That isn't what caused them to break the law. They need a treatment that will, and that's why I think it's a very good investment on the state's part to pay for it and do the investment ongoing. So just to give you an example, now Josh, it might not be true here, but from what I've read, you're talking about 3 hours of supervision a week and caseloads of 4 or 5 for MST. And that's why you get such a high quality result. That's completely and totally unrealistic to think about for a kid with PTSD or depression. That's not happening. So I think our state has made a good decision of where to invest in buying it at the ongoing, not just the basic training, but the ongoing. Now, our very good colleague and friend, Shannon Dorsey in psychology, has come up with a brilliant idea that she's testing in a big randomized trial, which is how can you come up with things that could be done within the normal supervision structure that would enhance fidelity to the EBP model. Now, she's testing this with TFCBT, but the idea is generic. She's had to pick a package because they're not going to fund something they haven't heard of. Because one of the things we've learned about supervision is not mostly clinical. It's mostly other things. So in Washington, our people tell us they get quite a bit of supervision. An hour a week or every other week. Plus, a lot of places have group supervision as well. But traditional supervision might involve, of the hour, 10 to 15 minutes clinical, like focus on what you're doing with your clients. There's support, there's crisis management, there's scheduling, there's performance evals, there's a lot of other things. That's what that article by Hogue talks about. Yes, people get supervision, but it's lots of things. So what Shannon has come up with is a model to try out 2 different things that you could put in clinical supervision. And one of them is monitoring outcomes and what people are doing in the supervision. So we have a web-based thing that was built, and that's a slight problem for sustainability, because where are the people going to get it? But she's testing that. They look at the clients. And then the other one is, in addition to monitoring what people say they did in their sessions during their regular supervision and outcomes, they have the providers get up and demonstrate, role play, what they're going to do at their next session. So you're seeing them demonstrate the skill. So it's a very cool study. It's very, Shannon is a genius, and I think it's a very good idea, because people get supervision. If we could come up with some lower cost strategies, they'll be harder, I might add, let me tell you. It's harder to have people do a role play or to plan ahead. Most people, when they talk about their cases, talk about what happened in the past, which is over. So anyway, but I think it's just very, very exciting. But it's the idea of something we could do that would enhance fidelity and outcome monitoring and build skills that you just embed in a standard procedure that people do. Now, the fidelity monitoring and QA, everybody knows that if you don't do that, people start to drift. That's not in question. The people kind of tend to go back because it is harder, and you have to be more systematic and more structured. In the paper up there, it's a family checkup. It's a brief little intervention, and they just showed when you don't have fidelity, the size of the results goes down. And I think everybody is fully aware of that. The problem is, how do you get that in a real-world setting without external funding and extra people? See, in a research study, you have extra people paid for by the study who review tapes or listen to audio and monitor whether people are doing what they're supposed to, and then you give feedback. But that's money to do that. So we have a practical suggestion, but it's very minimalistic, and it hasn't really caught on. But it's the idea of using a progress note, which is something everybody has to do. I did it this morning, saw a patient. I had to go in. We have a template. You have to put what the EBP model is, what component you did, what the scores on measures are, if you have them. So that keeps us honest in our clinic. Everybody knows that. And the very first thing it says, compliance with homework. Well, if you didn't give it, it's kind of hard to say whether people complied with it. So it's a great prompt for staying true. And it's also a way that our clinical supervisor could audit if she wanted to check up and see, is somebody really following the program? Because everyone has to do progress notes. So that's our entire big idea.
Would that be adequate to meet those providers, address those providers' fears about saying whether they did EVP or not in the reporting system in Washington?
Well, somebody has to recommend that with authority and say this would be good enough. Because right now, anybody in a mental health center, we get clinical audits every year. They come to our clinic, they give us a list of cases, and they review the charts. So my thought is, well, if people adopted the idea of a template that would have EBP stuff in it that even a non-clinical person could look at and say, yeah, that looks pretty EBP to me, I think that could suffice. But what people really want is providers to be marking what they did every session and somebody reviewing it. My own personal opinion, non-starter. I mean, where's the money? Even collaborative care, which the UW is very big on, and that's, an outcomes-driven system. That's not integrated with the EMR. That's a standalone, separate, multi-million-dollar project and hired staff who enter all the data and monitor it. But there are data, so the alternative to, are they doing the things the way the program says, is just measure outcomes. I mean, really, we're not in the business of delivering EVPs. We're in the business of helping people get better. So you could substitute outcome monitoring, which is exactly what collaborative care does. So PHQ-9s, basically. They're kind of flex on what the care managers can do. There are certain things they can do, but they're not told you have to do this session, or you have to do this much of that. But it's all driven by the outcomes. And as mentioned, they do have this fabulous registry is what they call it, where the PHQ-9s are in there. And if people aren't getting better, collaborative care requires a consultation with the psychiatrist on the team and the primary care doctor to figure out, what's going on here. So people don't just keep doing the same thing that's not working all over our time. And we have data from a study done by Len Bickman showing that just giving feedback to people actually improved outcomes without worrying at all about what people were actually doing. They didn't prescribe an EBP. But what I've heard, and maybe you guys who know him know more about this, I've heard he's abandoned it because he couldn't get people to adopt his method because it does require technology. That's an interesting factor, that if you can't get the information out in a way that, just like what I said about the EBP codes, if you can't get that information and feedback to the people it matters for, then it's kind of just data collection. Now, routine outcome monitoring is itself considered a form of an evidence-based intervention. Our colleague Aaron Lyons here at the U, he's very interested in that and very involved in that. And we do have an example, Group Health, in their behavioral health clinic, they require a progress monitoring tool, which I actually stole shamelessly from Brad Steinfeld. And every visit, whether it's the psychiatrist doing a med check or whether it's a therapist doing a visit, and they all get people to fill out a checklist. They walk in the waiting room, they get given a piece of paper, they fill it out, they take it into their provider, and the provider enters it into their, it's Epic. And so it can be done, but they've been able to create reports that go back to individual clinics, to the whole overall behavioral health system. And it's 30,000 visits a year, just by the way. It's a lot of visits. Now, I've heard from them that they've got the mechanical part done, but they're not sure people use the results in supervision or to tweak their treatment plan. And I just read a bunch of commentaries about routine outcome monitoring, which is, kind of a fad. It's a good one, I think, but, and it turns, one of them was so interesting, saying one of the problems, and I think Aaron Lyon ran into this in his review, well, most of these are proprietary. So there's a company who's come up with a routine outcome monitoring method and they sell it. And then what people have to do is, in addition to their progress note, then they have to go to a website and enter the data from their cases, and they tend to be not very flexible. And you can't say, well, we want to change up that measure. The one we use for our training, we can change a measure anytime we feel like it, because we're not a for-profit company. So it's kind of funny because that's the same thing, the parallel process with brand name EVPs. So how you would pull this off, to me, it's a technical and money problem. It's, in my opinion, a very good idea. My own personal experience, patients really like it. They like to see how they're doing. They like to go from 30 to 20 and say, wow, I really changed that much. So
will CBT Plus have... So do you think CBT Plus should have some sort of web-based support
We
thing
have
includes
one.
that?
We have one, but it's only for training, because here's what it would require. I mean, SMH could buy it, but they would have to have somebody who went in and entered every single client, and they would have to have all their people go into this separate website and enter what they did and the measures. That's what it takes, and we thought that would happen. They couldn't figure out our toolkit. We couldn't figure out how to integrate it with people's EMRs. So and I did get a sad email yesterday from somebody who was in the learning collaborative. Well, we turn it off when they're done, when they end after a year. They can't go in and just use our web-based system to put in their cases and track measures. I felt kind of bad about it because her whole organization would have to buy a subscription. So I don't know how to get there. That's what Jürgen does. He's got a whole thing, but it costs money to build it, and it costs money to keep it going, because somebody's got to put the cases in and put the info.
Well, it seems like the organization would have to be solely committed to using a single model for it to make sense, and then then it could happen.
Well, and I think that what they're doing at Group Health is the best thing we've got going, in the sense they don't go to an outside company. They tried that, and they gave it up because it was too big of a hassle and too expensive. So they use Epic, and they have, for whatever reasons, been able to pull out. They can do PHQ-9s. Now, that's not going to help us on the kids' side, because you can't. PHQ-9 measures depression. It's valid for kids up over 12, but it's not going to deal with all the different kid outcomes, and we see kids for a lot of things besides depression. But I think that they are onto something, and I think it's really worth learning more about it. So to me, our challenges are adaptation versus drift, leaving aside the paying for the training, figuring out how to get the supervision going and have it be 2 EVPs and monitoring fidelity and outcomes. Then we have this whole other thing, which is, guess what? People don't really want to follow the program, and they don't. As soon as the training is over, if it's not MST, people just start doing their own thing. And it's not a question about do they or don't they, it's how much do they do it. So adaptation is a good thing if it improves the care for an individual client, and it should be done. Cultural adaptations are good, tailoring, tweaking is good. One size does not fit all. On the other hand, drift is not so good, and that is really just going back to usual care. People are hopping around, do a little of this, a little of that. Some of it's consistent with EVP, some of it is not. So I thought it was hilarious when I was trying to do, in between Christmas and New Year's, it was kind of quiet at our clinic, so I did a lot of surfing of articles. Well, I thought these were kind of hilarious. This one, the first one up there, it's about ACTE, ACT, which is an adult intervention, sort of community treatment. And they were drifting before they even got going. This is the government in an initiative to implement EBP. And they were changing the model before they even implemented it. That should tell you something when people who think this is what we're doing are already. The bottom one, same thing. You can see the quote right out of the paper. These are quotes from the papers. They're not my interpretation. So the same thing. So think about what a challenge that is. An EBP initiative. People are modifying and adapting, and it's not just adapting to be tailored to patient clients. It's just going off the rails. Things that aren't consistent with model, that sort of thing. And providers adapt. They all adapt. This is from a study done on the match component-based thing. So that's why it's, did people use these interventions that they learned in the randomized trial? They only had to do 2 cases. Did they use it with their other clients? And if they did they adapt? Well, look at what you see. 92% of them. That's pretty much everybody. And sometimes it's for client reasons, which I think we'd all feel that makes sense, but sometimes it's the therapists and their preferences. And then sometimes it's organizational. So we've got it in CBT Plus. So we literally, I can guarantee you in basic training, we are not encouraging people to modify. We understand people will, but we don't say, hey, go out and modify. We say, try to learn to do it by the book, and then get creative once you really get comfortable. That's kind of a standard thing. Well, we give this measure, intent to modify, at the training. Over 90% of the people at the training are already planning to modify. And these are the different reasons. And one thing that's kind of disheartening to me, or to us, our team, is some of the reasons. So loosen session structure. Well, you've got 35% of the people saying they would do that for client reasons, which kind of makes sense. But what about that other group, 30% saying for personal reasons? So the modifying isn't systematic. It is some based on personal preferences and some based on, things that might make a good sense to do. So this is kind of the summary. Rosemary Mesa and Shannon are doing these analyses and this is kind of our result. The vast majority of people are doing it. They're doing it, on average quite often, but they're not really doing it in the bad way that often, which is like, well, let's just leave out the trauma narrative from trauma-focused therapy, or let's just treat the kid alone for behavior problems. So it's kind of good and bad, but it's a reality that we have to figure out how to, in my opinion, we got to embrace it. We can't, no, people are not listening to us. Now, there are Josh.
So I just want to clarify. So that was self-report, not going back and auditing, looking at...
Totally, everything is self-report.
Okay, which
Yes.
has a...
Well, that's all, its own self. But look at 93% of people are saying, I'm modified, and I'm modifying for personal reasons. So it kind of lends credence to the results as being accurate reflections. But everything is going to be, there's nobody, regular outpatient treatments, you're not going to have the opportunity to watch what people do and code it.
Okay.
Now, some adaptations, they're tested, and I think everybody agrees on this. Not everybody needs the full meal deal. So stepped care has been tested. Delivery of interventions over the internet, or have been shown to work very well, or integrated care. So those are things where you have an actual test of an adaptation, but it's a systematic test of a systematic adaptation. Cultural adaptations, they are ubiquitous. People who serve a primarily minority population always adapt, which is, I think, exactly as it should be. Now, the evidence doesn't show that it's necessary for results, but it's really more focused on engagement, on creating a service system, an organization that is welcoming to people from diverse backgrounds, that takes into account what people care about in their own communities, adapts kind of how concepts and things are explained to be fit and be culturally congruent. I think it's all good. None of the people are, by and large, there's one study that's really compared a cultural adaptation of an EVP with an EBP, and it actually, it can make things better and it can make things worse, because if you spend too much time on the cultural engagement part at the cost of not doing the active change ingredients, then that doesn't work out well. But I think from what I've read, people are very supportive of the idea of doing whatever it takes to try to help people from different backgrounds with different attitudes towards therapy, different circumstances, be willing to engage in the hard work of active therapy. Now, I'm involved in this project, and I think it's kind of funny because, again, here's a situation where the existing treatment, it's a juvenile justice one, ART, and the data show boys and girls do just as well in it. There's no need to adapt it for it to work better for the people who get it. However, everybody wants to send kids to gender-based interventions. And Sarah Walker did a study showing these made-up interventions that people came up with. Actually, some of them were making kids worse. So instead of trying to pound the table with the judges and the probation officers and say, you don't need it, she did the smart thing, and very luckily for us, Chris Hayes is the that's aggression replacement therapy guy in Washington. He's flexible. So we've created a girl version, has adaptation to things girls care about, addresses emotions other than anger, and we're testing it right now. So sometimes your adapting is being done not because it's needed, but because it will increase acceptability, whether it's to families and clients or to systems. Now, I will point out, everybody's doing it. The surgeons are doing it. Now, of all the things I thought they stuck to the program on, turns out, no, they recognize that surgeons need to have, and I love their quotes, I think it's hilarious, but they know it right up front. See, they're not trying to prevent people from doing what they are going to do anyway. They're trying to get people to say, no, which are the things you shouldn't go adapting on, and where does it not matter? And I think that is a kind of a neat orientation to it. When we try to stop people from doing human nature things, we generally don't work out that well. So I like this study. It was in focus groups and stuff, but I thought it really had some neat ways of thinking about it. Now, we have a little bit of a problem. Maybe the surgeons can all agree on what you don't adapt on. We don't have those data. We don't know what it is in these EBPs that's actually accounting for the change, for the good results, because they're all made up of a bunch of different things. Now, we know one thing, I think pretty good, Sue, which is you got to have the caregivers involved for changing behavior problems. And I think there's widespread agreement on that. That's a structural or a delivery method. That's not content, though. And on content, like the paper on core components of Robin Wiersing, it's like we don't really know. She does depression. Well, is it the cognitive restructuring? Is it behavioral activation? Is it coping skills? What is it? Because if we really knew, like the surgeons, these are the things you can't mess with, go out and mess with the rest of it. That's fine. So we don't really know. So here are my take-home points. On a policy side, I don't see this sustaining without some kind of external support or incentives. Like, what if we paid people more for doing the EBP that they documented that they did? I think people would be willing to invest more if there was something in it for them. On the practice side, I think we need to embrace adaptation and not try to prevent it, but we really, really, really need to get some consensus on what are the things you don't want to mess with and where can people do their own thing. So far as I'm concerned, for anxiety treatment, as long as you have exposure in it, which I'm pretty sure most people would agree, you have to have that, facing up to unrealistic fears. What do we care about the rest of it? I don't know. So flexibility with infidelity is something that Phil Kendall talked about 5 years ago or something. But we still don't know what are the things you can be flexible about and what are the things you have to have fidelity to. So anybody who has any brilliant ideas to solve this problem, please don't hold back. That's what I have to say.